Today we will have Dr. Angela Barado, HGF board member and assistant professor and pediatric endocrinologist at Connecticut Children's Hospital. Dr. Barado will present endocrine effects of relative energy deficiency in sports. Dr. Barado?
Hello, everyone. So today I'm going to talk about the endocrine effects of relative energy deficiency in sport, also known as REDS. So the objective of my talk for you guys is to understand the underlying pathophysiology of REDS, and we'll go through a little bit of normal physiology so that we can see what changes when there's this energy deficiency. We'll talk about the impact on the endocrine system, including bone health, and then I'll briefly go into a little bit of a management plan. We'll focus on the other two just because there's a very much a multidisciplinary approach to managing these patients. Okay, so everyone may not be familiar with the term of REDS, which is relative energy deficiency in sport. It's a fairly newer term. I believe, as endocrinologists, we've all talked about female athlete triad, which is the triad of having this relative energy deficiency plus oligomenorrhea or amenorrhea, decreased bone mineralization. But in 2014, the IOC, or International Olympic Committee, wanted to expand that. And the reason that they wanted to expand just beyond this female athlete triad is that they recognize that, one, it's not just females that are having these issues. Male athletes are also having decreased bone mineral density, and in both sexes, that there is more than just, sort of this little triangle being impacted. So there's a much broader environment. So there's cardiovascular, impact on the immune system, impact on your GI. And obviously, I'm not going to go into all of these systems, but I think that one allows researchers to have a broader view of everything, but also allowing coaches and those who are helping guide these athletes identify and realize that there's really a lot at stake here if these athletes are not having their energy demands met. So what is this relative energy deficiency? So in a lot of the literature, you're going to come across energy availability. And so energy availability, there's a few different formulations out there, but the one that I have seen most commonly cited is this one from 2007, Luke's paper. And so what that is it's your energy intake minus your energy expenditure divided by your free fat mass, right? So the food that you're putting into your body, the calories that you're putting into your body, and you're subtracting the calories that you're putting out, whether it's through gymnastics or running or cycling, swimming, any of these activities. So if you think, okay, well, if there's an imbalance here, so either the person is not putting enough calories back in, or they're burning too many calories, or a combination of both, you're going to have decreased energy availability left over. And if there's this decreased energy availability, then there's only so much that you have now for your daily living, right? And so you're going to shunt your energy to your needs for immediate survival. So things like fat accumulation, growth, development, puberty, those are not needed for your day-to-day survival. So those are going to get kind of taken away as a way to try to preserve the energies that's there. Signs, that come with RED. So there might be disordered eating. And so similar to patients with disordered eating for other reasons, in history, you may get reports of cutting out certain food groups or severe caloric restriction, use of diuretics, use of, medications to try to speed up your GI tract, skipping meals, binging. Other things that the patient might come in complaining about is fatigue, hair loss, cold hands and feet, dry skin. Obviously, weight loss could be a big sign. They may have increased healing time from injuries. Hey, I did something to my knee and it's really taking a long time to come back from that. They might be presenting, especially to an endocrine clinic, with stress fractures or multiple fractures. And then obviously another one that we would see in endocrine clinic is a teenage girl that's presenting with either primary amenorrhea, secondary amenorrhea, or oligomenorrhea. Another important thing to consider in these athletes is that they may struggle with low self-esteem and depression. Now, I'm talking about the energy imbalance here, and I was talking about disordered eating, but there's also patients that have unintentional energy imbalance. So I had a patient that I saw not that long ago with stress fractures and amenorrhea, and she said, but I eat healthy, I'm eating all of this food. But she was a 16-year-old training for a marathon. And so she, while was eating quite a bit of food, was eating the same amount when she was a cross-country athlete running, the farthest running 5 miles. If you're running 20 miles, more, you're going to need to increase your caloric intake. I think something here that's also important is you can have normal body weight and still have this low energy availability. It's not just somebody that truly has a low BMI, which I think, because sometimes that can get discounted, but they can have some of these abnormalities. So to go to physiology, so just to briefly go into some of the regulation of hunger, ghrelin and leptin are two of the major players. So ghrelin is a hormone that's produced and released mainly in the stomach, with small amounts being released in the small intestine, pancreas, and brain. The ghrelin has numerous functions. It has been termed your hunger hormone because it stimulates appetite, it increases food intake, and it will promote fat storage. Leptin is sort of the opposite, right? And so it'll inhibit where ghrelin activates in the neuropeptide-wide agouti-related peptide neuron pathways. And so leptin comes from the adipose tissue, so it's a marker of our energy stores. So after it gets released from our fat cells, it signals to the brain. It's giving information, right, about our energy status. And so studies in rodents and humans have demonstrated that when you've got leptin, you're going to decrease your food intake, you're going to increase your energy expenditure. It also has other various biological mechanisms, including related to our reproduction pathway. So leptin can be related to the initiation of human puberty. It also interacts with our immune and inflammatory responses, angiogenesis, bone formation, and wound healing. Some other players that we're going to come across being impacted in REDS. So adiponectin is another hormone that is expressed in adipose tissue. It's thought to be sort of synergistic with leptin in its activity. So it's involved in glucose metabolism and fatty acid oxidation and improves insulin resistance. Interestingly enough, even though it is coming from fat cells, there is an inverse relationship between generally body size and adiponectin levels. So we'll see that adiponectin levels are actually increased in patients with relative energy deficiency and actually decreased in patients with obesity, type 2 diabetes, and cardiovascular disease. I think most everybody out there is an endocrinologist, so I think we know the functions of insulin well as far as glucose and fatty acid metabolism. Incretins, they're a group of metabolic hormones that stimulate a decrease in blood glucose levels. So, right, you eat something, they'll get released. And so they work to help modulate the effects of insulin. They also are a marker of sort of energy stores, and so they will help to suppress our appetite. peptide YY also acts to decrease appetite. It's secreted from L cells in the small intestine. It's released into the blood from the intestine after eating. It binds to receptors in the brain to help decrease appetite and help make people feel full after eating. It also acts in the stomach and intestines to slow down the movement of food through the digestive tract. So this is, again, something that kind of helps to regulate our energy intake. So to go to the hormonal changes that are occurring in this relative energy deficiency. So leptin is lower in states of low energy availability and amenorrheic athletes, so those are females. This data has also been demonstrated in males, especially those that are in endurance sports. So, you know, things like marathon triathlons, things like that, which makes sense. If you've got lower fat stores, you're going to have lower leptin levels. Adiponectin, like I just said, actually shows that it's increased during caloric restriction, which seems interesting because you say, well, there's less fat cells. Where is this adiponectin coming from? Studies demonstrate that with long-term caloric restriction, you're going to actually have increase of adipose tissue developing in your bone marrow. And so the thought is that the adiponectin is coming from this bone marrow adipocytes. Ghrelin, right, the hunger hormone, it's elevated in women with anorexia nervosa and also in females with amenorrheic athletes. This data has not been demonstrated to be the same in males who have relative energy deficiency. Interestingly, though, in females with amenorrhea, anorexia nervosa, there actually seems to be an ability where they can suppress their response to ghrelin. So if you were to give ghrelin to a normal weight person, non-athlete, or even an athlete of normal body weight, it will increase their hunger, they'll increase their caloric intake. If you give it to somebody with anorexia nervosa, it may have no change in sort of their caloric intake. And so they have somehow developed the ability to kind of ignore that hormonal signal. And then interestingly, peptide YY is also elevated in amenorrheic athletes when you compare them to eumenorrheic athletes. It's also higher in males with anorexia nervosa. I did not find a good reason as to why it might be elevated, since it is trying to suppress appetite. All right, so moving on to the HPG axis. So low energy abundance is going to change, cause changes in the sex hormone levels in both men and women. So if you don't have enough energy availability, you're going to have changes in your LH and FSH, which is going to then have potential changes in your estrogen and testosterone levels. And if you think about it from sort of evolutionary standpoint, right, the body wants to make sure that it has enough calories to keep you alive, your day-to-day functions. If it feels like you don't have enough to do that, then that's not a very good time for you to have a child, you know, support a pregnancy, you know. So it makes sense that if you have low energy availability, that you're going to take away your reproductive function as a way to conserve energy. So as I mentioned earlier, leptin plays a role. So leptin does help promote the kisspeptin neurons, which then help promote GnRH secretion, right, which then is going to help promote LH and FSH secretion, whereas ghrelin is going to suppress that. So, you know, if you have high levels of leptin, that means that you've got a lot of energy stores. If you've got high levels of ghrelin, high levels of the hunger hormone, right, maybe there's energy deficiency. And so if you're, you know, got enough energy on board, then that's a good time for you to, you know, go ahead and have your normal reproductive cycles. So this was the study that I alluded to a few slides ago that was looking at LH pulsatility in patients that were getting different amounts of calories. So 45 kilocalories per kilogram was the normal sort of caloric intake, and then they did a lower caloric intake of 10 kilocalories per kilogram, 20 and 30, and they looked at the LH pattern. And so the arrows that you see are where the meals were given. The black bars demonstrate lights out, so demonstrating sleep time. And so the top bar is the normal. So there is normal, pulses and amplitudes of your LH secretion throughout the 24-hour period. Then if you look at the next with the 30 kilocal per kilogram treatment, there really didn't seem to be any impact on either the pulse frequency or amplitude. But then if you move over to the 20 kcal per kilogram, you start to notice there's a decrease in the frequency of the pulses, and you're having higher amplitudes. And then if you go over to the 10 kilocal per kilogram group, they have, much less in the way of the LH pulses, and they're having these higher amplitudes, which is then going to change the signaling to your ovaries, and it's going to change your estrogen production. This is another study looking at amenorrheic athletes to athletes that are having menses. And so on the left-hand side, again, you can see these LH pulses. So the amenorrheic athletes, they're having less pulses versus the eumenorrheic athlete, and then, the non-athlete. They're having higher levels of these ghrelin concentrations, and they have much lower leptin levels. And so there, demonstrates the correlation, the interplay of all of these. And so on the right-hand side, again, comparing sort of the LH pulse mass to ghrelin and leptin in the, in all subjects versus the amenorrheic athletes. And there's, a much more significant sort of correlation. So testosterone, so there have been studies that have evaluated testosterone levels in females with low energy availability. There haven't been consistent data. So in some studies, the testosterone has been elevated, unchanged, or decreased. If a patient is coming to you in the office, we still need to keep other reasons for amenorrhea or oligomenorrhea in our mind. So if there's elevated testosterone, we still have to, keep PCOS on the differential. Male athletes are at increased risk for low to low normal testosterone, especially if they're engaged in sports. Again, those endurance sports where you're just going at it for really extended periods of time, or sports that promote leanness. So, horse jockeys, they have to be of a certain weight. Wrestling, when you're actively wrestling, right, you might be restricting your calories and things like that to get to a certain weight class. And that can have an impact on their testosterone. And with wrestlers, there can be differences between, when they're on season versus off season. Off season, presumably they're not kind of having, the restrictive calories, the increased physical activity that they would have during the season. And so Hackney, proposed exercise hypogonadal male condition where basal, free, and total testosterone concentrations were reduced. However, there were not consistent elevations in LH levels like you might see in primary testicular failure. Growth hormone access, so looking at growth hormone and IGF-1. So low energy abundance states seem to demonstrate growth hormone resistance. So, right, growth hormone is necessary for bone and muscle anabolism and metabolism of carbohydrates, proteins, and lipids. So growth hormone is stimulated by hormones such as ghrelin. And some of the effects of growth hormone are mediated by IGF-1 and some of them are not. So IGF-1 made in the liver, right, to growth hormone stimulation. So it seems like there is some growth hormone resistance when it comes to production of IGF-1. However, some of the non-IGF-1 mediated effects of growth hormone, like carbohydrate metabolism and lipolysis, seem to be preserved when there's energy deficiency. So, growth hormone can help maintain euglycemia in these states of low energy availability without necessarily withdrawing, everything from the fat stores. And so the IGF-1, right, that's growth. You don't want to grow if you're not getting enough calories, but you still want to help to maintain your glucose levels. So this was another study that was looking at growth hormone and IGF-1 levels, right, with energy availability. So this is, again, sort of the higher calorie diet per day versus calorie restriction. And they demonstrated that there was, higher levels of growth hormone being secreted when you are on these lower calorie diets versus your IGF-1 and your IGF binding protein 3. So hypothyroidism. So oftentimes there is a sick euthyroid that is seen. However, below in this chart, there's quite a difference in thyroid function when people are looking at athletes with this relative energy deficiency. The things that seem to be most consistent is a decreased total T3 in both male and female athletes, and also a low-free T3. You can have a normal TSH, you can have a normal or low-free T4, so these might not be as good of markers. And so some people in the literature have proposed maybe we should be looking at T3 and free T3 in these patients as sort of a marker of thyroid dysfunction, but also the thyroid dysfunction being a marker of the relative energy deficiency, right? Another marker to help guide us in, managing these patients, because as their energy availability improves, then, these other things should get better. So this is just a study that was comparing a bunch of things, but I just wanted to focus on the T3 and demonstrate that there was a significant difference in T3 levels in the amenorrheic versus eumenorrheic athletes, or the low testosterone, normal testosterone male athletes. This study didn't really demonstrate significant difference in IGF-1 level, insulin level. So HPA access. So caloric restriction is associated with increased circulating cortisol. So cortisol is secreted when there's prolonged exercise, starvation, glycogen depletion. So in animal models, the CRH at the hypothalamus, right, it's going to directly affect our GnRH positive neurons, modulating GnRH release and attenuating pituitary LH pulsatility. So this is actually, correlating to some of the amenorrhea, right, the changes. So, what came first as far as HPA access? Is there increased CRH? Is it increased cortisol? What is modulating these things? And then again, in men, since we haven't been looking at them as much from the sort of relative energy deficiency as long. We don't have much data. There, one study listed here really didn't show a difference in men depending on their energy availability. So bone. So many of the hormones that are discussed in this presentation have a bad impact on bone. So right, if you're having suppression of your hypothalamic pituitary gonadal axis, you're going to have decrease of your estrogen, testosterone. That's not good for your bone. If you have decreased leptin, that's going to have negative impact on your bone. Decreased IGF-1 is going to have impact on your bone. Increased cortisol, increased peptide YY. These things are all going to, you know, pile on together and have impact on your bone. I think for a long time people said, well, you know, is it just in these female athletes, right? Is it just amenorrhea? Is it just the, you know, changes in your menses, the low estrogen that's contributing? But, you know, the studies really are coming out and showing that it's not just, you know, your low estrogen that is having an impact on your bone. So again, studies have demonstrated in amenorrheic athletes that they have lower bone mineral density. They have impaired bone micro architecture, estimates of bone strength. They have increased risk of fracture. Again, I think that this is probably a common way that these patients are presenting. They have stress fractures, and I mean, I've seen stress fractures of the spine in athletes, of the femur in athletes who, you know, when you kind of get into the history and then obviously you do your lab work, it is consistent with energy imbalance. Like I just said earlier, it's not just the low estrogen that's contributing to bone loss. As I just said, you know, when an athlete is presenting with stress fracture, that might be the first sign to pick up that there's low bone mineral density. So, you know, getting a DEXA is a perfect way to evaluate for the bone density. As with, I think, most things, there's not as much data on the male athletes. However, there are some, especially those, again, that are participating in the sports that emphasize your leanness, so to have, you know, sort of that lean body mass, are more likely going to have low bone mineral density, especially, you know, compared to, say, a basketball player or a football player where you're having that kind of high impact and multi-directional bone loading, which is going to, you know, help to increase sort of the signals on your osteocytes and have good bone formation. I think in our adolescence, one of the reasons to, you know, really be mindful of the bone and the bone mineral density is that, you know, adolescence is the time of bone mass accrual. And so, you know, menarche in girls is a signal of, you know, mass bone growth, and about 25% of bone mass accrual occurs in the 2 years around menarche, right? And so, you know, girls are going to accumulate till their late teens, early 20s, males maybe a little bit longer. And so if they're not doing that because they just don't have the calories to do that, you know, they're really setting themselves up not only for issues now, right, with the stress fractures and things like that, they're setting themselves up for long-term increased rates of developing osteoporosis. So this was a study comparing patients, men and women, so 11 eumenorrheic women, 11 you know, with abnormal menses, and then men who either were on a controlled diet of that normal sort of 40-45 kilocalories per day, or a restricted diet where they got 15 kilocalories per kilogram. And so in this study, they were looking at bone markers as sort of a marker of bone health. And so in the first one, they were looking at beta C terminal telopeptide, which indicates increased bone resorption. So when you have these increased levels, right, you're going to see that in osteoporosis, osteopenia, anything where you're having this increased bone turnover, bone breaking down. And so in box A, on the left-hand side is the men, and on the right-hand side is the women. And so the solid color bars are those who had the normal calorie. The striped bars are those that had the restricted calorie, and you can see the area under the curve that they were having increased of this beta C telopeptide. So those with the energy deficiency are having, markers of increased bone resorption. The next box in the middle, box B, so that is procollagen type 1 N-terminal propeptide. And so this is a marker of bone formation. So again, in the left-hand side, those are the men, the right-hand side are the women. The solid bars are the those that were getting normal calories. The ones on the right-hand side are those who had the restricted calorie intake. And so in the women, there was a statistically significant difference in the people who were restricted. There was sort of a trend of difference, although not statistically significant in the men. So then you're putting together, right, you're having increased bone breakdown, decreased bone formation as suggested by these markers. And so when you put the two together and looking at the bone turnover ratio, it's not statistically significant in the men, but it is statistically significant in the women, that they are having increased bone turnover. And so, that they're setting themselves up for osteoporosis, for low bone mineral density. This was this was more data from the same study. So in the top, they were looking at markers of calcium metabolism, so PTH, calcium, mag, and phos. There was no significant difference in the markers of calcium metabolism. They also looked at sclerostin, and there wasn't any significant difference in the, in women there were. In men, there was no real difference in sort of the levels. And overall, the responses in sclerostin appear to be higher in women compared to those men, which can be a main side effect of sex. All right, so to get into evaluation and treatment, so screening, so as endocrinologists, we're probably not going to be the ones that are screening a lot of these patients. Usually they're going to be coming to us because of an lab abnormality, or because they had a fracture, or because they're not having their menses. But the IOC did release something here, and so they break it down into lights, right, red, yellow, and green, as to whether somebody is high risk, moderate risk, or green risk. And so the high risk, right, do they have serious eating disorders? Do they have other serious medical conditions related to low energy availability? Are they using some of these extreme weight loss techniques? Are they using, the diuretics or laxatives, or wearing the sweatsuits and like sitting in a steam room? Or do they have evidence of severe EKG abnormalities? So, if you're in this sort of red light, it's, you can't be participating in your sport. You need to have a contract and have a plan in place of how you're going to help, reduce your energy deficiency. In the yellow light, do you have a low percent body mass as measured on DEXA? Have you had a huge weight loss? If you're a teenage athlete, are you growing and going through puberty as expected?
I don't have a line on it, right?
Are you a female who's having irregular cycles, or have you not had any menarche by the age of 15? Have you had a DEXA where maybe there's decreased bone mineral density? Do you have a history of fractures? Do you have maybe a little bit of disordered eating? And so these things are maybe not as severe. And so with the moderate risk, it becomes well, we can let you participate, maybe not to the same degree that we would otherwise, but it's the kind of thing where we're going to keep a close eye on you and reevaluate you every 1 to 3 months. And then there's the green light. Yes, you're eating appropriately. Yes, you have a good body weight. Yes, you don't have any issues with growth, development, reproductive cycles. So, really the goal of treatment is to resume a positive energy balance. And so the treatment plan is really going to depend on the patient. So if this was a patient where maybe there was unintentional energy balance, right? The patient or the athlete didn't realize that, they weren't giving themselves enough calories. It wasn't something intentional. Maybe they just need to work, well with a sports nutritionist and kind of get themselves back on track with close monitoring. If there's disordered eating, then the patient is definitely going to need a much more disciplinary approach. So they're going to need therapy. They're going to need nutrition. There's going to be different physicians that are involved in the care. And if this is a patient, right, just like patients with anorexia nervosa, if they have severe disordered eating, then they may need inpatient care. Adolescents and young women, which is where most of the data comes from, who have a severe energy deficiency, they can develop hemodynamic instability, bradycardia, orthostasis, right, as you're starting to refeed. And so they can have electrolyte abnormalities. So these are things that need to be closely monitored. And so that might not be something that you're just going to do as an outpatient. I think one of the things that I'd love for people to come away from here, and because this is a common question that I get when I go to general pediatricians' offices, are, well, what do we do with the amenorrhea, right? So first you want to make sure that you're ruling out other causes, right? Because you don't want to just say, oh, well, it's REDS and miss a prolactinoma or miss, PCOS or things like that. But the menses are sort of, in females, are a marker of their energy deficiency, right? So as the energy availability improves, their menses should start to occur. This can take time. The average time has been reported as long as 15 months. But I know that it's distressing to the patient and distressing to us to not see these menses happening. And so I have seen, again, out there where OCPs get started, right? OCPs are going to kind of mask the problem. They're going to cause withdrawal bleeds, but they're not actually doing anything to fix the underlying, LH pulsatility. And, again, you can use your menses as sort of a marker that the patient is getting back to where they need to. The one place I think that, people do, think about are, well, maybe, we're worried this is a low estrogen state. This is going to impact bone mineral density. There's, OCPs do not increase the bone mineral density in patients with anorexia nervosa, and the Endocrine Society guidelines do specifically advise against OCPs for the sole purpose of regaining menses or improving bone mineral density. In fact, there's lots of literature that's out there that suggests using OCPs, you're actually going to, decrease bone mineral density. So just don't use them. Obviously, if there is a need for contraception, I think that's a very different conversation to have with your patients. I think something to also tell your patients is just because, right, so if you're right, they're in feeding therapy, they're meeting with their nutritionist, they're meeting with their psychiatrist, just because the menses haven't come back yet doesn't mean that ovulation isn't starting. And so it is important to discuss with these patients about alternative uses of contraception. I can think back to when I was a track athlete in high school. I remember one of my teammates saying, oh, well, I can have as much unprotected sex as I want. My fat mass is so low that I don't get my period. And I mean, even as like a 15-year-old, bells went off in my head, is like, there's a lot of stuff that's not right here. But you know, this is how kids are going to think. And so certainly we would not want an, you know, unintended pregnancy. There is some data to suggest that using estrogen patches, you know, could potentially be a benefit for bone mineral density. Again, I think just trying to get this patient back to the calories that they need, restricting how much they're burning up with their exercise is the way to do it. You know, I think as far as then, you know, treatment of the bone, again, we want them to gain their weight and resume their menses. That's going to be the best thing to help with their overall bone health. You know, you do want to sort of support the bone. So I would recommend checking a vitamin D level and kind of aiming for a nice, robust vitamin D, making sure that these girls are getting, or men are getting enough calcium. You know, a lot of times they're not having dairy or they're cutting out dairy, but there's plenty of calcium-rich foods, leafy greens, you know, orange juice that's got calcium in it, as a way to try to make sure that they're getting all the calcium that they need. Again, I think another question will come up as, you know, do we need to use bisphosphonates or denosumab in these athletes? And so at this point, there's no strong recommendation in using it for these athletes for their low bone mineral density. If the amenorrhea does go untreated, you know, females will continue to lose a bone mass of a rate of about 2 to 3% per year. So it's really critical for these young female athletes and young male athletes to understand that even, you know, having this relative energy deficiency for 6 months or a year during their adolescence can have quite a significant impact lifelong for them. Just some final thoughts. Again, these are my little pearls. I know I went over a lot, but if there's nothing else you remember from this, the treatment for these patients is improving their energy availability. So that's going to be a multidisciplinary approach. Low energy availability can occur in normal weight athletes. So it's not just somebody with a low BMI. So especially if a athlete has, you know, really increased their mileage, if they're running, or, you know, they've already started to cut down, they have some orthorexia, right? They're focusing on super healthy foods, but still not giving themselves enough calories. They can, you know, have some of these effects. And then birth control pill is not recommended for bone health or for the amenorrhea in these patients. So those are just some of my references. If anybody has questions, you know, emails as a way to contact me.
Thank you so much, Dr. Barada. That was an excellent presentation. We now have a couple of questions that we'd like for you to answer. Please stand by. This one is an anonymous person, and they'd like to know, can AMH levels differentiate level leans PCOS from RED?
That is a good question. I did not come across too much about the AMH levels in these patients. I would expect that they'd have fairly normal levels. I honestly would have to look that up versus, the elevated levels that we can see in PCOS.
Okay, thank you. Can red be considered a variant of functional hypothalamic amenorrhea?
Yeah, so the reds is, there's overlap, right, with functional hypothalamic amenorrhea. And so basically what's happening, right, is you have decrease, you have changes in your GnRH, your LH, and your FSH, because your body is trying to shunt away. If you're not getting the calories, that's a bad time to, have normal menses, have ovulation, try to get pregnant. And so, yes, they're kind of a continuum of the same thing. It's just with the red, you're going to see the other, right? You're going to see, other changes.
Doctor, do you get an MRI for amenorrheic athletes to make sure there is no pituitary lesions?
If it's a pretty clear, if the history and the other lab testing are consistent that this looks like reds, then I do not get a pituitary MRI. If it's a patient where there's not that history, right, of decreased caloric intake or increased energy expenditure, then I would. I can think of a patient fairly recently who is a large girl who is not an athlete, and I certainly did get an MRI on her, and we did find a pretty large cystic lesion on the pituitary. But my girl that I saw pretty recently, who did have a normal BMI, but did have what looked like hypothalamic amenorrhea with stress fractures. We did not, and I actually referred her to my adolescent colleagues for some more intensive nutritional and psychotherapy. And so we're going to continue to follow her until her menses resume.
Another question, is there any target positive energy balance recommendation while managing these conditions?
So, there is, there are goals of weight gain, of a few pounds per month. I think what the specific caloric intake is going to vary quite a bit on the deficiency where the patient is at. And I'll be honest, I often rely on my nutrition colleagues to help me come up with a good game plan for that.
Okay, here's another one. Can you elaborate more regarding data on use of transdermal E2, as it has been shown to have positive effects on bone in AN, especially when restoring caloric intake often may be challenging and or insufficient?
Yeah, so I can think of two studies. So there was a study, 18-month study that looked at 96 females that either got transdermal estrogen with cyclic progesterone, did have greater gains in their spine and hip BMD-C scores than if they had been on a placebo patch or pills. However, it wasn't a large enough study or long-term enough to really know if that did anything to help decrease the incidence of stress or fragility fractures. There was a second study that was done in 121 oligomenic female athletes that were young, adolescents, young adults, that did also show some benefits with transdermal estrogen, where there were changes, I believe, in the hip and spine BMD as well on DEXA. So, I think that there might be some potential benefits for that, especially if it is, I think, kind of in looking everything up for this talk, if if the patient is exceeding like the normal rates of recovery, so if this is something that's going on for, years and, they're not getting back, that might be the place where you might consider using an estrogen patch, just because you're right, at some point you do have to kind of weigh the pros and cons of, trying to do it just through caloric intake alone, versus it being a much more, versus sort of helping to protect the bones. So I think, overall, all the society guidelines don't recommend it. But I think if you're going to individualize it to patients, it's not something that I would do across the board to anybody. But this would be something that I would do in the patients who, maybe it's been 2 years and they're not having, resumption of their menses, or, their bone mineral density isn't improving on DEXA, to help, potentially, minimize effective, for osteoporosis long term.
Well, I think this question goes along with that. They're asking, could you please specify for how long you use estrogen patches and the dosage?
So I personally do not use estrogen patches in my patients. I've been fortunate in that I've been able to, have patients resume their menses within sort of that 18-month time frame. If that person, I can certainly look that, up and have a discussion with them offline if they wanted to send me an email.
Okay, because another person asked, how long is too long to respond treatment? I have a patient going on almost 2 years.
Yeah, I mean, I think at the 2-year mark, closer, I think extended period of time, 2-3 years, that's when I might consider, adding that to my treatment plan. I would also, see what's going on with their DEXAs to see what's, where their bone mineral density and bone accrual are at. I often at that point would, from the beginning, I definitely get my adolescent colleagues involved as well, because I think that they're often helpful in addressing, improving the caloric intake of these patients. Because if it's going on that long, they may benefit from, much more significant, cognitive behavioral therapy and things like that.
Okay, 1 second. Let me just see. Well, I think that was it. I think we got most of the questions answered. So okay. I just wanted to thank you for a wonderful presentation.